we must first understand what is trauma. And the definition that comes out of NASMHPD for trauma talks about the experience of violence and victimization, and this includes sexual abuse, physical abuse, severe neglect, loss, domestic violence, and or the witnessing of violence, terrorisms, or disasters. And in this whole definition, you can see that it's very global. It talks about a number of different abuse elements, some of which aren't part of our routine inquiry when we do have our talks with individuals. But it helps us to understand that there is a global definition that probably, when we take a look at the population that we serve, encompasses a very large population. In the U.S., we have our Bible for the mental health field, which is called the Diagnostic and Statistical Manual, and the DSM-4-TR. It talks about trauma as a person's response. And this is important to distinguish because this is the person's response to you rather than your identification of what you conceive to be their traumas. And this response involves a lot of time intense fear, horror, and helplessness. But more importantly, the stressors that it brings to the individual generally overwhelms their capacity to cope. These two elements are essential in understanding about the trauma perspective because it is about identifying what happened to a person as opposed to what's wrong with the person. The types of traumas resulting in serious and persistent mental health problems, it needs to be clarified and understood that it's usually not a single event. It's not like we come to know in diagnostic realms that if somebody has an event occur, we call that their trauma. It's usually not one element that takes place. For instance, something like a rape or a natural disaster or an abuse of any sort. We also understand that not only is it multiple in its nature, it's also very interpersonal and it's very intentional. And for most individuals, it's also prolonged, it's repeated, it's severe, and all of these capacities combine together to give rise to their presentation. These trauma events don't necessarily occur in adulthood, but can occur in childhood and adolescence, and when you look at the statistics, more likely occurs in childhood and adolescence, and hence extends over that individual's lifespan. And you look at the reason why is mostly because if it occurs in childhood or adolescence, generally there is no book to go to, and quite often in a lot of abuses also does not involve being able to talk to even family members who do understand. When we talk about trauma-informed care, the definition of trauma-informed care is a form of treatment that incorporates an ability to appreciate the high prevalence, first of all, of traumatic experience. I want to break this into two pieces here because first and foremost, the difficulty we have as mental health teams, as assessing individuals, is that there is a lack of appreciation for its prevalence in terms of traumatic experiences. We need to also understand that it's a combination of effects in the body, and those effects may be neurological, they may be biological, they may be psychological, and they may be social. And all of these combined give rise to the presentation that the individual generally shows. With regards to the prevalence of trauma in the United States, and the first one deals with the public mental health clients, who are most of the people that we see. And what it says is very compelling because if you look at the data and look at the number, it tells us that the majority of individuals we see, 90% of the public mental health clients in the U.S. have been exposed to some form of trauma. And I ask you to recall what I said a little bit earlier about multiple forms of trauma. Do not go in looking at an individual as one element of trauma because you will miss so many others. Now, the third one has to do with, in the United States, the large percentage of homeless women, 97%, who have a serious mental illness, have experienced some form of severe physical and sexual abuse. Roughly 87% have experienced this abuse both in childhood and adulthood. And the message that you gather from this is in the delivery of anything that is called trauma-informed care, the majority of individuals that you speak with will have this historical perspective in their background, but if they are homeless and they are women, the prevalence ratio is a great deal higher. With the prevalence of trauma, they did a study involving the child mental health and youth detention population in the United States. They did 100 adolescent inpatients, and what they discovered is that of these 100 adolescent individuals, 93% had trauma histories, and almost a third of them had PTSD, or post-traumatic stress disorder. In this, they also investigated looking at young ladies who were incarcerated, and they discovered that anywhere between 70 and 90% of them have a history of sexual, physical, or emotional abuse. And I want to take the "or" out of it, because in some situations you'll find that "and" is a much more appropriate usage. The Canadian study that was done involved roughly 190 adolescents, and nearly half of them had reported histories of post-traumatic stress disorder. Other critical correlates, we take a look at a study done by an individual who I've had the pleasure to work with on a number of occasions. This gentleman's name is Vincent Folletti. He discovered that there were a number of health risk behaviors that a lot of these individuals were using as coping mechanisms. This was no small study by any stretch of the imagination. He did a study of 17,000 individuals. He looked at things like eating disorders and smoking and substance abuse and individuals who harmed themselves or even had kind of a promiscuous lifestyle. And he looked at the correlates with regards to how many were coming up with heart disease, pulmonary disease, liver disease, and as well early death. So this became his focus with regards to what was going on. In studying the same thing, he did a 10-item purview that involved more mental health components, and he asked the questions of the 17,000. How many had any recurrent or severe physical abuse? How many had recurrent or severe emotional abuse? How many kids had sexual abuse? How many kids grew up in a household with an alcohol or a drug abuser, or a family member that was in prison, or anyone who was mentally ill, chronically depressed, or institutionalized? How many kids had mothers who were treated violently, or in another case having both biological parents absent from the home? And how many had emotional or physical abuse? Now, you ask yourself the question of the population that you serve, how many people would have answered a majority of these questions in the positive for one person saying this? And why that's important is because of the findings from this particular study. What Dr. Folletti discovered is that any male child who answered 6 of these questions in the affirmative had a 4,600% chance of becoming an IV drug abuser than a male child, who answered none of the questions to the affirmative. His question was, is this drug abuse that is seen in these prevalence statistics a self-destructive act, or is it a desperate attempt at self-healing, albeit while accepting the future risk? And what he really was saying is, are people using to get over the traumas? Because in a majority of individuals that we've had, the evaluative components that we work with, very few do it because of recreation. When you really get into the questioning, as I'm sure you have discovered in the population that you serve, a majority of individuals are, in one sense, attempting to self-medicate. What happened to that individual, as opposed to what's wrong with them? Dr. Folletti also said that addiction is best viewed as an understandable, unconscious, compulsive use of psychoactive materials, but also in response to abnormal prior life experiences, most of which are concealed by shame, secrecy, and social taboo. So again, one can look at this and one can embrace it, or one can take a step back and take a look at their own population that they serve and see if it best fits the definition of who you are serving. Because what he's saying is that, is the addiction a self-serving component? Is it a self-medicating prophecy? Albeit failed, but more importantly, albeit understood by the individual as a desperate attempt to try to conceal what is going on in the traumas in their life. So what does the prevalence data tell us? From what you've been presented so far, it tells us that the majority of adults and children in psychiatric treatment facilities, A, have trauma histories. It also tells us that a sizable percentage of people with substance abuse disorders have traumatic stress symptoms that interfere with their ability to keep themselves sober. And lastly, a sizable percentage of adults in the prison or juvenile system have trauma histories. What it says is, in any assessment of any individual, please, please, please assess trauma history. Ask the individual what happened to them, not what's wrong with them. So in trauma-informed care systems, the key principles that we want to look at in delivery of care is to A, integrate philosophies of care that guide all of their clinical interventions. B, take a look at where your data is coming from. Look at current literature, look at current interactions, look at current studies that take a look at compassionate delivery of care. You want to also make sure it's inclusive of the survivor's perspective. This is a lost art in the form of what we used to do in the past, where we actually asked our clients, our patients, what happened with them, and we listened. We also need to be informed by the recent research and the effective practice that is going on now. And lastly, recognize that coercive interventions cause traumatization, yes, but also by our own hands and by the hands of the system that the individual may be involved in may re-traumatize them. And we need to be not only A, aware of it, but B, be able to avoid any re-traumatization at all possibilities. The key features involved in trauma-informed care is to look at things that we have been doing ever since we started interacting with others. First, value the individual in all aspects of the delivery of care. Secondly, be neutral. Be objective. Help the individual by promoting supportive language. We tend in our interactions with others to be very degrading and very controlling and very, very punitive in our language with individuals. You want to be neutral, objective. Think about the individual and help support them in your interview features. You also individually design their treatment plans. Don't go in looking to fit the individual into a treatment or a diagnosis. Instead, you want to be flexible in accordance with their traumas, in accordance with their self-regulation, in accordance with how they are seeking alternative strategies. It's quite possible that once you start into a key treatment plan, it may need to be modified, but do not modify it alone. Finally, avoid shaming the individual. Avoid humiliating the individual. Once you shame an individual or humiliate them, you have lost them as a potential interviewing client. I've said this before, and it bears repeating over and over and over. Sandra Bloom, a trauma survivor herself, speaks of this across the country, focusing on what happened to you in place of what's wrong with you. In addition, ask questions about abuse. Now, I'm a practicing psychiatrist, and I've been practicing for roughly 28 years, and I can tell you that it's usually the psychiatrist that is the major one that does not ask the questions. And you want to address the risk by asking those questions and help that individual to plan for their safety. And the word safety can never be overutilized in an assessment. The third piece here is something I really want you to focus on because it does not seem by itself to be an important factor, but is critical when you're doing trauma-informed care, and that is that one person should be asking the questions and doing so in a compassionate way. Lastly, note that people who are psychotic and delusional can still respond to trauma assessments. The real big issue is how they are approached and asked. The unfortunate part about our field is that quite often, if a person has already been labeled as psychotic and delusional, we quite often go down the road of saying, well, we can't assess them. Neurologically and psychologically, the individual is able to still absorb the trauma treatment and assessment elements. You just need to focus on how you ask the questions. This slide shows the difference between trauma-informed interventions and non-trauma-informed. And the non-trauma-informed category that you see on the right may remind you of some of the things that you're doing, some of the things that you're not doing, but otherwise can really show the difference why it is that this treatment is so crucial in this manner. You look at the first one that talks about a recognition of the prevalence of trauma. The problem is right now, in the non-trauma informed community, there's lack of education. There's lack of determination of prevalence, and as a result, a lack of what is referred to as a universal precaution. The universal precaution as it involves trauma-informed care is to ask about the trauma history. Secondly, a recognition of primary and co-occurring trauma diagnoses. Because as many trauma survivors will tell you, they have been diagnosed with everything that the DSM-IV could offer. One young lady who's a very, very noteworthy trauma survivor that we have with us, Ms. Tony Kane, would quite often talk about how she would go to the emergency room on a Monday and be diagnosed schizophrenic, go on a Wednesday, be called bipolar, and go on a Friday and be called a conduct disorder. And in all of those circumstances, her main question to each of the assessors is, how can you diagnose me when I've been smoking crack for the last 20 days? We need to assess for the trauma histories, because we don't do it. We need to recognize also about the culture and the practice, because many cultures, many religions have certain attachments with regard to the shame, taboo, secrecy that's quite often involved in the abuse, sexual, physical, that may occur. Instead of our non-trauma informed approach, which is kind of like what the family does to a large degree, which is to say to them, buck up, just get yourself together, be tough, and everything will work out okay. The power and control needs to be minimized. We need to take a look at that element of culture, because re-traumatizing events can be very much identified by the individual but missed by the assessor. And you see examples on the right side involving things like keys. And one would think that keys wouldn't necessarily be a re-traumatizing event, but when you put the rest of the trauma history together and you begin to see that this individual, like the young lady I was speaking about before, would have male visitors at her mother's home while she was 9 years old and upstairs in the bedroom, and the re-traumatizing and traumatizing event for her was when her mom would fall asleep and she would hear the keys of the boyfriends jingling as they were headed towards her room to sexually abuse her. Look at the caregivers and supports collaboration, because we need to connect the team. The team needs to involve more than the team. It needs to involve the individual. It needs to involve what caregivers are associated and supporters. Instead of presenting how the hospital, the setting, the individual, clinic or otherwise, or the one-to-one connection has these rules, and we must comply by the rules. So as you get into actually working with clients and you take a decision, or you make a decision, that goes to the left of the regular way that we do things, immediately staff says we can't do that. And when you ask the reason why, they say, well, there's a rule against it somewhere. Lastly, we need to address the training needs to take a step backwards and understand that this is fluid not only for the patient or the client or the consumer, but it's also something for us that helps us to improve our knowledge and improve our sensitivity, instead of putting it all in the patient's side and blaming them for everything that we do. The staff needs to understand the function of behavior so that it is not taken personally, because we tend to look at behaviors as something they're doing to us instead of understanding why the behavior even exists to begin with. A reiteration of how we speak: use objective, neutral language. Don't get into the labeling language. Now, coming through the residency program that went through, quite often we immediately would say that if we had a person who was labeled as a borderline personality disorder, that was the same as having 20 regular patients, and we need to avoid that. Lastly, transparent systems open to outside parties. We tend to keep everything in the room, when what is helpful is a full understanding of the events that have been involved in this person's trauma. I think at this point that ends this particular section on what is trauma.